Are you a PA or an NP who is curious about the opportunities for us to work abroad in other countries, or just curious about whether our professions even exist in other countries? Well, today I am going to be diving into those questions about South Africa. Hi, my name is Michelle. I'm a practicing PA, and this is my channel, The Medicine Couch, where I explore all kinds of opportunities open for PAs and NPs in the US and around the world.
Hi, I'm Navesh Moodley. I graduated in 2018 as a clinical associate.
Clinical associate, is that the profession that's the most equivalent of a PA in the US?
Yes, it is the most equivalent of still very new in South Africa, and thus the laws are still yet to be amended to accommodate for the profession in the country. It has been introduced in 2008, and the first cohort was done in 2011. And what was nice about the profession is that we had support from the provinces and the National Department of Health that assisted in the very early stages of the program. And I think the profession has been really grateful to that initial push into government, and then later on, the private sector has seen the value in the profession itself, and has taken it and has molded it to their idea of what a clinical associate is. The opportunities in private has really opened the eyes of the healthcare sector to the benefit of having a mid-level healthcare worker in the country.
Yeah, I mean, well, every profession's got to start somewhere, right? And
Yeah.
so it's going to grow and evolve and things. But we're going to dive in and talk about all of those kind of topics. But first, I'd like to kind of establish what a clinical associate actually is, like as far as what duties they perform and what the scope of practice is there in South Africa.
Currently, in a broad consensus about the scope of practice, it is a supervised profession, meaning that it cannot function independently, so to speak, regarding the legalities that can exist with it. There is a clause for a 1 to 2 year direct supervision, a 2 to 5 year indirect supervision, with that extension into 5 year plus, where there is minimal supervision, meaning that you can have a medical doctor at the telephone, and that's okay as supervision. When it comes to prescribing, the Pharmacy Council in South Africa, SHAPRA, regulates medicine in the country, and they have not listed clinical associates as legal prescribers. And that goes back
Mm.
to specific laws that yet have to be amended to accommodate for that. SHAPRA is okay with how clinical associates are trained in the country for pharmacology, but these laws at place do kind of, how can I say this, inhibit the whole process of that.
Right.
It's an interesting one. I guess Rome was not built in one day, and these processes are ongoing, and it's going to be one of those that we actually take on for a few years.
Okay, but how do you guys handle prescriptions right now then?
So, clinical associates are trained in the country to write a script. So, in essence, the idea is a clinical associate sees a patient, presents that patient to the medical doctor, who is the superintendent at the time, and presents the medication choice. And if the doctor agrees, then it's countersigned and sent to the pharmacist. So, in a nutshell, we train clinical associates to take patient histories, perform the physical examinations, order and interpret diagnostic and therapeutic procedures, formulate diagnosis for common and emergency conditions that is listed in the burden of diseases in the country, develop and implement treatment plans, and that includes pharmacological and non-pharmacological plans. They can monitor therapeutic interventions for patients, assist in surgery. They are able to provide counseling and education to patients, and make appropriate referrals where necessary.
I didn't realize the profession there is quite new. It's in its infancy, I guess you could say.
Yeah.
So it'd be interesting to see how things develop. So do most of the clinical associates in South Africa work like primary care, or do they also work in the various specialties?
Initially, when the program was started in the country, The focus was to bridge the gap. It's to relieve the burden of patients that doctors see by providing a healthcare force, the mid-level healthcare worker that can take on those conditions that are listed in the burden of diseases in the country. Those are the high ones, and that's what we train them for. And in 3 years, I mean, it's a relatively short time. Uh, by the time they are graduating, they should have insight into treating most of these conditions at different levels and where necessary to refer them.
When you say the registered diseases or burden of diseases within the country, are you saying that the CAs there are trained on just certain disease processes, that the ones you would see most often in primary care, and then that's where they work, or can you clarify that a little bit more?
To quickly allude to the burden of diseases in the country, it's a list of
Mm,
conditions that South Africa sees the most, and it's a lot with our
okay.
population. So we're talking about diabetes, hypertension, maybe more or less the
Okay.
same in the States. But yeah,
Yeah.
dyslipidemia, it's HIV medicine, it's TB medicine. In South Africa, we have the primary health care, we have district, we have CHC district, we have a regional or a secondary hospital, and then we have the tertiary, and then the super specialized hospitals that all provide different levels of care. And clinical associates in the country started off, was created for the higher burdened places where patient load was a lot, and that is your primary health care and district level
Yeah.
care. And now, many years later, clinical associates still practice in those settings, but clinical associates also, like myself, started off initially in a regional facility and in family medicine and practiced at that level from the get go. And then you have clinical associates who have gone straight into private, straight out of graduation, the assisting in surgeries, the assisting in procedures, and work in speciality, neurology, orthopedics, in cardiology, ophthalmology, and so on, the various specialities.
And the name clinical associates, I know other countries, various ones have gone with physician assistant, and others have gone with physician associate. So I'm kind of curious, do you happen to know why South Africa went with clinical associate?
Some of the American terms are not very fluent here in the country. So
Okay.
the clinical officer is widely used across Africa. So the
Oh,
clinical
okay.
setting, and I think it lends to that, that you're not just assisting the doctor or the physician, but rather you're assisting in a clinical setting, and you're an associate
Yeah.
to that setting. And I think where we get a bit confused now and again, the appropriate abbreviation for a clinical associate is not a CA, because in South Africa,
Oh.
that is a chartered accountant, and that's the appropriate
Oh.
abbreviation for a chartered accountant. And rather, it is actually ClinA with a full stop at the end.
ClinA. Okay. Yeah, that's interesting. And, I was thinking when you were talking, it actually kind of would have been nice if we had gone with something like clinical associate, because part of the confusion and frustration around our name is the fact that the physician part of the name, confuses people, and it also annoys physicians a little bit too,
Yeah.
especially when we change to physician associate. So it kind of would have been nice if we had something originally that was totally not associated with physicians and can stand alone as its own profession.
Yeah.
So do you have an idea, or do you have the numbers of how many ClinAs are actually working right now in South Africa?
In the studies that are ongoing, we see clinical associates that are employed in government still, clinical associates that are employed in private, and we talk about other, we're talking about the research space, medical IT, and everything else that falls under that, where clinical associates go. And it's nice to know that clinical associates are not just limited to the clinical space, but find spaces outside and permeate those spaces. And I love that. I love that so much. And those are important things for the profession, especially in its early stages. So currently practicing, we don't have a lot of clinical associates that are practicing, and I think the job spaces are are not always accommodating for the profession when they don't know the profession. And we still struggle
Hmm.
with that in the country where people don't know what a clinical associate is. In the country, we get around 150 to 180 graduates every year from the three
Okay.
universities that train clinical associates in the country. Around the first year and second year of graduation, it is sometimes a bit of a struggle for graduates to get a job, and then they do. On average, we look around about maybe 3,000 to 4,000 clinical associates in the country that are still practicing, and that's okay for now. It is.
It's a young profession there. I mean, we've been around in the US since 1965, I think. We still struggle sometimes. It's much better now. Like, you don't always have to explain what a PA is. A lot of
Yeah.
people, even the general public, knows, but there are still people that don't know or really don't understand, what our training and our scope of practice is. So I can't give you any hope that it's going to get much better anytime in the near future for you guys. It's going to be a long struggle. But I think as the profession grows around the world, like you said, if people recognize the name, physician associate or physician assistant, that can help you guys. I also too love that you talked about the fact that ClinAs can go in different areas in and around kind of medicine and science, technology, those kinds of things, because I think so many PAs in the US have such a limited view of what they can do. And so I'm always trying to get that out on this channel, is that we have training that can take us in so many directions. So I love that, and love to see that that's happening already with your profession, even though it's so young over there. So the other question I was thinking when you were talking earlier, and when you said you have to kind of educate people on what a clinical associate is, and here in the US, I mean, sometimes I still have to say, if people don't know, I have to say, well, do you know what a nurse practitioner is?
Yeah.
And there's probably 3 times as many nurse practitioners in the US than there are PAs. And so people are more familiar with them. And they'll say, yeah, I know what that is. I say, okay, well, we're very similar. We just have a different training. So I'm curious, do you guys have nurse practitioners there? And is their scope of practice similar to a clinical associate's?
So, yes, we do have nurse practitioners. So, we have two different registering bodies for the professions. We have SANC, the South African Nursing Council, and we have HPCSA that governs all allied healthcare workers, the medical and dental board in essence. So, their scope of practice is regulated by their regulatory body, a SANC, and clinical associates, we are registered with HPCSA. That's our licensing body. The clinical nurse practitioner, that's the term in South Africa. The regulations are different. A clinical nurse practitioner can prescribe till Schedule 4, and they can prescribe and dispense with the license, and they can actually prescribe without being countersigned. It's so because clinical nurse practitioners have been written into the law in the country. It is a profession that has existed for hundreds of years, and it's expected.
Yeah. Yeah.
So their
Yeah.
specializations are accounted for and regulated and legalized. So too with doctors. I mean, doctors' processes have been regulated and legalized and reformed and formed over hundreds of years. And then you get the clinical associate since 2008, the very, very
Yeah.
young child. And even though there is overlap in the trainings, there is no comparison that is drawn. The comparison that stuck very early in the profession was, are you half a doctor, half a nurse? And you're
Yeah.
like, no, I'm a clinical associate. But then you
Yeah.
explain to them all of this, and then they're like, "So you're half a doctor, half a nurse," and
Yeah.
and that still it, you know what? It's
Yeah, it
okay,
gets maddening, yeah.
but there's no comparison
Uh,
that's drawn to nurses in the clinical
oh,
nurse
okay.
practitioner space. A clinical nurse
Okay.
practitioner functions by themselves according to their regulations.
So they can work and diagnose and prescribe and all that, and they don't have to have supervision?
Yeah, so once it's a 1 year post grad for them, actually. So once they're done with their 4 years of nursing, they do the one additional year, whether it is a PHC, which is primary health care, whether it is psychiatry, emergency medicine, or what. whatever other subspecialty they can actually specialize in and get a nurse specialized in that. Their scope, of course, limits them. They are limited to the PHC space. So
Mm,
beyond
okay.
that district hospital level, it becomes difficult for that profession or that specialty to practice.
Yeah, that's interesting because that's similar, so similar to how it is in the US. PAs, when we come out of our training, obviously our training is focused in family practice, same the way you guys are
Yeah.
trained in the core medical problems facing the country. But we're trained as generalists, so we actually can go into any specialty. Whereas the nurse practitioners here, it's a little bit different here because for the most part, they specialize by population. So either pediatrics or geriatrics or just women's health. The one exception I think is psychiatry. So they have a specific certification for psychiatry, but they have to work in those particular areas, so they can't as freely change around like we can. So it's interesting to see that that kind of has evolved that way in South Africa as well
Yeah.
for clinical associates and nurse practitioners. So I'm curious. You talked about right now there are three universities training clinical associates. Are the universities standardized, or is the program standardized? And then is there some kind of national test or some kind of standardized test you guys have to take before you get licensed?
We don't have board exams by the licensing body for the country currently. There is hopes that it will happen, and that will afford us the opportunity to become independent practitioners. But what the universities have done from the get go, or very early into the program's inception, is to write what we call the CANE exam. It's a Clinical Associate National Exam that the three universities sit together in a panel and we write that exam or formulate that exam, have it quality checked by the university standards of it needs to be moderated and then moderated again, come back, panel beated, approved for printing or whatever the case may be. And we do that whole process. The students all write on the same day. So that somewhat helps us standardize the training, so to speak. Apart from that exam, you have what we also call the KNOSCI. And that is also the practical exams. And that is also governed in the same structure. The curriculums, I wanted to speak quickly about the curriculums. It's a 3-year undergraduate degree that is NQF level 7. So the national qualification framework in the country governs the placement of qualifications. So 3 years, the credits are specific for those 3 years, what we're training in those 3 years. All of the curriculums across the three universities, they're all written differently. Some are run in blocks, some are run in modules, some are run in rotations, and it's all different. But at the end, the CANE exam is a true test to see, are we training correctly according to our specific curriculums that are designed and tailored for that specific university? And I think it's a very, very nice exam to quality check and to measure the output of and quality of students that we put out, or graduates rather.
Yeah. And so, like, our schooling is set up, and as far as PA school goes, we do a 4 year of undergrad, but you have to take things like, I don't know, history and geography or whatever. The same thing for medical doctors. We have to take all this fluff that doesn't really matter. I mean, it all matters, but you know what I mean. It's not
Yeah.
like stuff that we have to know for it. And I think our schooling could be condensed. Anyway, so we do the 4 years undergrad, and then PA school is 2 to 3 years, depending on the program and how fast they move you through. But basically, we do 1 year of didactic, like almost every school I think is set up this way. So you 1 year of book learning basically, and then the next year you do all of your rotations. I think you guys have it set up a little differently.
We lend to hybrid learning. Ideally, we try to facilitate self-directed learning. We are trying to train critical thinkers. In the first year, yes, we do make use of didactic learning where we present lectures, and it's still very, very behavioristic. We teach you something, you learn it, we see how that is cognitized in your mind and how it is now translated in that. But from the first year, the clinical associate students are placed, put into the hospital space. Yes, of course, very simple stuff like taking a history, let's do a physical examination and see what happens. Let's call it soft launching them into the health space. That's
Yeah.
what we're essentially doing.
Oh, I love that.
Yeah,
Yeah.
soft launching them into that space. So ideally, in the first year, we're looking at the normal findings of taking a history, doing a physical examination. The second year of the study, we are focusing on how do I take all of that information and formulate a differential diagnosis, taking into consideration investigative studies and so on. And in their final year, how do I formulate a management plan? And we use the biopsychosocial model, and that's family medicine. So yes, so in the 3 years, that those are broad focuses. So it's not just all book learning. They do have the basic sciences in the beginning, in the first year, anatomy, physiology, computers, computer sciences, depending on the university, whether it's another language they have to learn because South Africa has quite a few languages and we want them to learn a different language to be able to communicate with the locals. So we don't do didactic learning and heavy on it or any at any point in any tertiary learning in South Africa. A lot of it is self, or everybody's moving towards a self-directed learning approach, and how do we facilitate that? And we'd like to think facilitation of learning over teaching and education. How do we
Yeah.
facilitate learning?
I really also love the fact that you guys are getting the students into these clinical settings in the first year. Even like you said, it was just learning physical exam and doing all of that hands-on stuff intertwined in with learning the medicine, because I think it solidifies it so much better in your brain when you can kind of learn something and equate it to something you're actually physically seeing. So I love that you guys are set up that way, and I wish that we were that way in the U.S. Since this is an undergrad degree, I assume that your student population are people that are just coming out of high school, or do they have to work clinically at all, or in some capacity, or have any kind of training before they get into the clinical associate program?
So I think it's an unsaid something, and I say something as a placeholder. It's an unsaid something that in your grade 11, grade 12 years, the field that you're interested in, go and do something in it to see if you really want to do it. Let's start there. Let's benchmark and say that that's the unspoken rule that we'd want people
Yeah.
to do before they come. Not all of them do. They hear about the program somewhere along the way. It sparks interest, or they have a mindset that is planted. But yes, our intake is usually 17, 18, 19-year olds, 20. And then you get those few outliers that have studied something else and decided, I want to do BCMP after that. So that's,
Yeah.
23, 24, 25.
I was wondering how ClinAs are being accepted by the medical community and then also by the general public. And I know that with the caveat that a lot of people still don't know what what they are. But for the ones who know what they are, is it a positive reception, or is there kind of negative, some negativity brewing about the profession?
Look, if I had to be really honest with you, I don't think any new kid on the block will have it smooth sailing from the get go all the way in.
Yeah.
We do have our challenges, and starting first with the healthcare space, we had to somewhat fight and still fight to have a space in health sciences, which shouldn't be the case.
Yeah.
We are our own specifically trained people that provide a level of care. And I think the misconception from doctors is, are they going to replace our GPs? And I think that was a
Yeah.
very big concern. Then it was the concern of they don't know enough, and failing to understand that the profession was not put forward to take on the role of a doctor and to know
Yeah.
everything and to function at that level. It was to bridge a gap. And the training is
Yeah.
limited to do just that, to bridge a gap. And whatever you learn after that, from what we're trying to train you to do, then that lifelong learner
Yeah.
is entirely up to you and the doctor you're working with, or the space you're working in, rather. And that's quite specific. But yes, we've had our pushback from health sciences, doctors, specialists, nurses, even the allied healthcare workers. I think we struggle a lot with allied at this point because they don't really know what a clinical associate does. With the public is quite receptive, and I think in the public space, and I'm not talking about private, but in the public sector,
Right.
patients are grateful for being helped. And I think that's the first and foremost. If someone can listen to them and hear their story and not treat them like another stat or an object and just trying to push a line, because I mean, a
Yeah.
lot of patients are being seen on a daily basis, and our facilities and our healthcare team cannot handle the burden. So
Yeah.
they're just grateful if someone can listen to them, and
Yeah.
that's enough. And so publicly from the public clients, no. Private, not
Yeah.
always, but you will have your catchment of patients that are, yeah, I don't know what you are. I do not want to be seen by you. I want to be seen by
Right.
my doctor and my
Right. Yeah.
specialist and my. So you do
Yeah.
have
Yeah.
that, and that's fine.
Yeah, and sometimes you just wanna shout from the rooftops. It's like, "Look, there are enough sick people to go around for all of us." There's a need, right? That's why this
Certainly.
was all made. But you're right, patients just want somebody that listens to them and can spend a little bit of time with them.
Yeah.
So I'm curious, about pay in for clinical associates. So it's hard because you could tell us how much they make, in your currency, and it's not going to, my audience in the US is gonna be like, "That means nothing to me." But if you could somehow give us an idea of the pay.
So it differs, and in government, of course, they pay according to your educational level and the NQF level as
Mm.
well. So it is already structured into government. At this level, we pay this level, and that's it. In private, it's easier to negotiate the salary based on what services you're providing. If I had to take a medical doctor, and I'm talking about a really, really experienced medical doctor. On average, a clinical associate is earning about half his salary, if not just more than half his salary, which
Okay.
is
Yeah.
quite a significant amount on average. Then you get those who
Yeah.
earn slightly less than that, and then of those who actually practice in government, which is on the lower end, and that is just very entry level. You can survive on it. It
Yeah.
won't afford you the
Okay.
luxuries of life, but it would afford you a roof over your head
Yeah.
and the fundamental decencies of life, if I had to say that, yeah.
When you say government, that is the healthcare that everyone in the country has access to, I suppose? And is it government funded? And then the healthcare professionals who work in the government sector, they're paid directly by the government? Is that correct in that?
100% so, yes. So in the public sector, every hospital will get a budget. Personnel that's hired in that hospital gets paid by government. They are government workers funded by the National Department of Health.
And then the patients that are getting their healthcare in the public sector, do they have extra money that they have to pay for their healthcare, or is everything basically covered?
We don't always have everything that we need in government. And that's a sad, sad thing. From equipment, sometimes we have it, sometimes we don't when it comes to imaging studies. For example, a CT scan can be broken for months, and now we're sending patients who need urgent CT scans somewhere else, or MRI scans. I mean, MRI machines are not always available. X-ray machines can be broken. Similarly, so with the medications, not always everything is available. And we struggle from time to time with the pharmacies in the hospital running out of their budgets to provide the medications.
But in general, like if somebody needed to have an operation or something that's kind of a
Yeah,
standard
funded by
operation,
government.
um, then they don't get a bill in general.
They would pay a small
Oh,
fee.
okay.
Depending on the hospital, a hospital will charge you like a small administration fee. Uh,
Oh, okay.
maybe like $2 or $3, if I can say that.
Oh.
$2 or $3.
So not like in the US, like if you have to go, even if you have health insurance and you go and you have an operation, you're likely still going to be paying $5,000 to $10,000 on your own, even if you have health insurance here.
Oh,
So,
shucks.
yeah. So I'm just trying to get an idea of that. And then the private sector, when you talked about that, people, I assume that they have like a private health insurance they buy and then they can access that private system. Is that correct?
Yes, it's just dependent on the clientele base. And in private, most patients will have a medical aid. The medical aids are governed in the country. Some of them will require a co-payment, while others won't. Those co-payments can pour into the thousands, and expectedly so.
Yeah.
So yeah,
All right. And when you say medical aids,
health
I'm taking
insurance.
that's kind of insurance. Yeah, for them. Okay. A question that I know a lot of USPAs wonder all the time, and if you can speak to it, NPs as well. You may not know the answer, but is there any opportunity for US trained PAs and or NPs to work in South Africa? And I guess even beyond the US, if there's PAs or NPs trained in other countries, do you know if they're allowed to work in South Africa?
There are two PAs that I know in the country that are registered as clinical associates. Both belong to academia and have been
Mhm.
part of academia, but registered with the regulatory body as a clinical associate in the country. Perfectly fine. We've never had any issues with that. We have had exchange programs from other universities where we had PAs come and teach for a few months. We've had clinical officers from Africa. With clinical officers in Africa, we have them write in the final year exam. They will attend the final year, then be registered as a clinical associate in the country. Regarding clinical associates going out, I know in the UK currently they have opened their board exams for clinical associates to write. That's very interesting and very nice. So yeah, I think there's the international platform is opening up for clinical associates, and the South African platform is accommodating for the international physician associates, clinical officers to work in the country. Yeah.
Do you have any idea where people would even start if this is something they were interested in, like specifically wanting to move to South Africa and looking, for work there? Would they start with like the medical board or the licensing board and contact them first?
Yeah, so usually it's kind of that exchange program. You make a connection, you know someone that assists you in the whole process. But yes, the people to have made contact with would be the regulatory bodies and to be
Okay.
licensed, because you cannot practice anywhere in the country without
Yeah.
having a license number. So to practice, yes, you have to start there and then enter the job market. Otherwise, employment may not be possible.
And if somebody like was coming from the US, the likelihood that they would speak Afrikaans or whatever other languages, are down there would probably be slim to none. Would it be possible potentially to work just knowing English or even to teach there just knowing English? Like is all instruction done in English or what is the kind of state of languages there?
Right. So predominantly, so English is the medium of communication and teaching and learning. It's a recommendation that you do speak another language or try to learn. In our white population, Afrikaans would be predominantly so. And if you are in places like Pretoria, it'll be ideal that you can speak Afrikaans, because also the black population will be able to speak Afrikaans as well. Then you go to provinces like KwaZulu-Natal, and our more African languages are spoken, like isiZulu. In Eastern Cape, Xhosa is also spoken. You have people that speak Sesotho, Pedi, and sometimes a mix of
Yeah.
all the languages. And that happens from time to time.
Yeah, that seems like a challenge having so many different languages that can potentially be spoken. Okay, well, this has really been eye opening, and I've learned a lot. And I appreciate you taking your time and kind of telling us all about the clinical associate role there in South Africa.
You're most welcome. And thank you for the opportunity to put out clinical associates on a global platform.
If you're curious about the PA role in other countries or want to learn about how PAs and NPs can work abroad, then check out this playlist here.